Hi, I'm Marwan Bukhari. I'm the consultant rheumatologist and the editor-in-chief of the Journal of Rheumatology, and welcome to the webinar. And today I'm actually going to be chatting to Lizzy MacPhie, who was the chair of the Standards Guidelines and Audit Working Group, a consultant rheumatologist, and now chair of the Clinical Affairs Committee and a trustee of the BSR. And we'll talk to you a bit about what's more recent, about what's been published regarding the very quickly changing guidances that have been coming out from the different societies and the patient societies regarding what's happening with COVID-19. Lizzy, thank you very much for agreeing to be grilled. This is quite a tricky thing, and a lot of people have been asking a lot of questions, so welcome aboard. I understand you work in Lancashire, is that correct?
Yes, I'm based up in Preston in a community-based rheumatology service, which is part of an integrated MSK service.
And I'm based in a hospital service in a teaching hospital, so it's going to be quite an interesting one to see different perspectives on the same thing. So really, there's been quite a few questions, really. Shall we start off with the first ones? I mean, NICE, NHS England, and the devolved nation equivalents, the BSR, and other organizations have published lots of resources. Can you just guide us through them? Because, you know, a lot of people will be very confused. What do we follow? What are the key messages, really?
Okay, so probably worth highlighting is the BSR guidance itself, and how the BSR have been making our members aware of all the different documents that have been developed over the last few weeks, because there is an awful lot to navigate through and to understand how each one applies and is there to help your service. So the BSR guidance and the updates for COVID-19 are updated on a weekly basis. It might be at first glance, if you log on and have a look and then look on a week later, you might not necessarily realise that things have been updated and extra things have been added, because it's been a resource that we've continually added to rather than necessarily publish just the new bits each time. So that's important to realise, and if there has been major updates, then we do send out a notification to members as an email just to highlight to members what's changed. But what we've done within that is we've signposted people to various documents that have been developed. NHS England on 16th of March published a document which was a specialty guide, and the BSR was involved in contributing to the writing of that together with our CRG lead, and that's just in the process of being updated at this moment, and an updated version will be published probably next week. But that helps us to stratify the risk to our patient group across all of our rheumatological conditions, but also equates risk on the basis of medications as well. So that guidance is really helpful and probably was pivotal in helping departments to understand what was priority as pressures on the NHS started to ramp up. What could we start to step down as services? So that guidance has been really helpful to just help teams to have discussions with managers around what's priority and what can be stepped down. Okay. And to complement the NHS England, it's probably just worth highlighting the NICE rapid guidance that's been published this week, because that pulls out some of the key points from that NHS England guidance to help teams.
So if you actually want to tell somebody who doesn't really want to go through reams and reams of paper what the bottom line is, what do you do with high risk, what do you do with intermediate risk, what do you do with low risk, what are the headlines for each one of them?
So what it does is it apportions risk, and I think it's fair to say that most of our conditions, most of our drugs put people into the vulnerable, the high risk, and the very high risk categories. So that's where we come on to the stratification guidance, which is about identifying those at the very highest risk, those patients who were worried about if they contract COVID-19 are at high risk of complications and more serious illness. And that guidance is a little bit different, and that's actually been the key focus for the BSR and the working group that was formed of various different members to develop that stratification guide, and that's been, I think it's fair to say, a very rapidly developed document, and it takes into account patients' medications, their DMARDs, biologics and JAK inhibitors, and also medication in the form of steroids. It also acknowledges that age plays a part and comorbidities as well. And so patients are then apportioned to being very high risk on the basis of these combination of factors. And there has been some confusion, and it's felt some discrepancy between the NHS England guide, which mentioned that all biologic patients were at high or very high risk, and our stratification guide, which didn't put patients on a single biologic drug into the high risk shielding group. And it's important to realise that our guidance had to be developed in line with other medical specialties. So the Chief Medical Officer approached the medical specialties and each of the organisations, similar to the BSR, to develop their guidance for their specialty. And there were meetings that took place between the specialties to make sure that we were aligning our guidance. So you didn't have one specialty advising that all patients on a biologic go into the shielding group and another saying, well, actually, we don't think that quite applies to patients on anti-TNF drugs, so we're not going to put everybody into the shielding group. And there also had to be a consensus reached about other immunosuppressive drugs, mycophenolate, azathioprine, methotrexate, which are used across the disciplines, and also about the dose of steroid that was deemed to be high risk. So there was an awful lot of work that went into developing that stratification guidance in a very, very small, very tight time scale. It was actually developed over a 4-day period with lots of teleconferences between the specialties as well as just within our working group, and lots of revision of the guide to make sure that we got that right.
So that's the reason, basically, that you went for a national level agreement, because I completely agree with you. The way that we deal with azathioprine is a great example, as versus the Gastroenterology Society would be very different. So is that why there's been such a very careful wording of all of these?
I think it's
yeah.
I think it's been important that there's alignment across the specialties, but the other slight spanner in the works was that there were alerts sent out to certain groups of patients who were identified nationally through NHS Digital. So all patients who were prescribed mycophenolate, azathioprine, tacrolimus and sirolimus were notified directly through the national flagging system that they were in the shielding group. And it was flagged that this may put patients who we haven't actually put within our guide into the shielding group, be notifying excessive numbers. But it was felt that these patients were more likely to be patients who'd had organ transplants, and these were medications that would be used for that basis. They were felt to be very high risk. But there was acknowledgement after those alerts went out that actually there will have been some patients who wouldn't fall into their specialties stratification guidance, who were being notified that they're in the shielding group. This was particularly pertinent to patients under gastroenterology who were on, well-controlled inflammatory bowel disease on low doses of azathioprine, who were receiving shielding letters. So there has had to be some correction to patients when inquiries have been made, but it wasn't put upon specialties to have to go and alert all those individual patients. We've dealt with queries as they've come up.
Okay, so it has been quite an interesting one, because the one thing that a lot of our patients tell us is, where is my letter? My neighbor next door was on the same drug and got a letter, and where's my letter? I'm on a much worse drug than they are. And you think, actually, yes. So whose responsibility do you think it will be to, for all of our patients that we stratify them? Do you think it's the individual rheumatology departments who should really be signposting their patients? Should it be the CCGs looking at things? Should we be employing pharmacists to do it? Because these are the questions that we've got, and we don't have answers to be fair, in secondary care. I'm not sure.
It's yeah. Well, it's coming up now. It's 2 weeks since that guidance was published, and there was notification to all of our members that it was the responsibility of the rheumatology teams to identify these patient groups. And we thought very carefully about this, because when we were drawing up our guidance, there were options to take, an easy path to say, well, everyone on a biologic should be shielded, because then you can identify everyone through your home care providers and get letters out to everyone. But it became apparent that that wasn't appropriate because of the numbers on biologics, and also because of the numbers on these drugs being prescribed by other specialties as well, who didn't deem that a single biologic was enough to put them into the shielding group. And we have a responsibility that, this is meant to be a cohort of 1.5 million people. We can't go over identifying patients because there isn't the resources there. And also, it wasn't felt that there was actually the risk to those patients. So even though the evidence around COVID-19 in patients on biologics is very limited, we have got some data that's come out of Wuhan. We've got anecdotal evidence coming through the registers, and we're not seeing huge numbers of patients on immunosuppressive medications who are doing badly. Not lots and lots of reports, but it's difficult, and it was very difficult drawing up the guidance. But it was recognised that it was quite a complicated stratification approach that was needed. So we needed to know about the medications, some of which are prescribed by primary care, some of which are prescribed by secondary care when it comes to the biologics. And then you had to also take into consideration their age and their comorbidities.
Well, that's exactly
So it was,
the question.
yeah.
How about when you've got a patient on a biologic and has comorbidities? How do you stratify the comorbidities? Because we've got patients, for example, who will have fairly stable asthma, to patients with COPD, to people who are hypertensive and badly controlled diabetic. They're very different stratification strategies, aren't they?
Well, what we acknowledge with the comorbidity side is that that having one comorbidity and age fell into that. So being over the age of 70, or having another comorbidity such as diabetes, ischemic heart disease, hypertension, underlying lung disease, that could be COPD, asthma, bronchiectasis, or ILD related to their underlying rheumatological condition, and chronic renal failure. Just one of those, if you like, scored you as a comorbidity. So if you had two or more comorbidities, so if you were over the age of 70 and diabetic, you didn't rack up more points. It was a case that just one comorbidity added to your risk. That's what we acknowledged. And it was difficult, but what was developed to accompany the actual stratification guide was a scoring system to allow services to be able to just very quickly go through each patient and score them up. So you got a point, if you like, for whatever medication you were taking, and then you took into consideration comorbidities and whether or not they were on steroids, and then you added up the points for each patient, and then that would tell you whether or not they fell into the shielding group. And that guide's been really helpful. So when it comes to then the process, it can only fall to the rheumatology teams, and different teams have taken different approaches. We all deliver our drugs through home care providers, so lists from home care providers, those patients who are attending for infusions, you can identify quite quickly. The difficulty for lots of patients is the DMARD cohort and identifying those patients who are on a small dose of steroid alongside and other comorbidities. But just to give you an example of what we did within our services, we collated all the home care lists, all the infusion patients. We had a list of everybody who was under us for shared care, and then we literally went through all of those patients. For those on just DMARDs, we just picked out those on combination therapy, and remembering that sulfasalazine and hydroxychloroquine aren't counted as a risk. And then we identified those. So we screened around, I think it's about 2,500 patients, and we identified, to date, we've identified 210 who needed shielding, and they've all been then sent letters, a copy letter to their GP to ask them to code them as COVID-19 high risk. And we were fortunate that each patient we were able to phone and explain to them what this meant. But we've been lucky, we've had the resources to do it, and not everybody has had the resources.
Yeah, as somebody I'm going on to a respiratory COVID ward tomorrow morning to do a ward round, which is something I haven't done for more than 19 years, and a general medical ward round is something daunting, but lots of the hospital rheumatologists are being dragged in to actually do other things. So it is actually a resource heavy thing. How about health professionals who are high risk? What special considerations are there for this? I mean, I can understand that the guidance is very nice and clear about the denosumab, etc., and and zoledronic acid and how you can do it. And there's some very nice, some nice guidance there for the jobbing rheumatologists. But what about health professionals? Because that's something I get asked all the time. I'm being stopped in the corridor, patients saying, I'm on methotrexate, I'm on azathioprine, I'm on a biologic, which ward can I work in?
Mm-hmm. I mean, it's quite easy if they're in this. If they meet the criteria for shielding, then that's very simple. They should be at home, and they should be self-isolating for 3 months. So those ones are very easy to deal with, and we've had some queries through from patients around that. The difficulty is, like you say, those patients who are on methotrexate or single biologic or even on combination therapy, and I think this is where you need to interpret the guidance, which is that those patients should be adhering to strict social distancing, and it may be their preference that they do self-isolate. And so the discussions that I've had with a number of health professionals is that if you can't at work adhere to social distancing safely, then you need to reconsider how you're supporting the NHS and need to be redeployed to a slightly different role. So I had a discussion this week with an ophthalmologist, and he's basically said that he will support the department by doing telephone appointments and reviewing patients remotely, but he can't get involved with doing the on-call for his specialty because he would be too close. He wouldn't be able to maintain that social distance. So I think it's difficult. And I think we probably, or I don't think there's a right or wrong. I think you've got to have that discussion with each individual patient.
Yeah, and you have to just look at what the drug is. So, for example, I've got a health professional who works in the respiratory ward where he's doing all the appropriate things and is on leflunomide and has been stable on it and is quite happy to go and see patients. But I had the conversation about risk, and I think that's the way to do it. You have to take each individual patient as they come. And the next thing is, how about hydroxychloroquine? Is there a stockpiling issue? I mean, in America, after that ill-advised message from the president of the States, it seems as though there's lots of problems with hydroxychloroquine. Is there a supply issue?
So we have had some members emailing through to highlight that they've had some issues with patients reporting to them they've not been able to get their hydroxychloroquine prescriptions. We have been informed that there was a slight issue with the supply chain, but that has been rectified. And we flagged it to NHS England, and the chief pharmacist has given us assurances that there is no problem with regards to the supply of hydroxychloroquine at this time. As I'm sure you'll be aware, Marwan, that in the recovery trial for COVID-19, one of the arms is using hydroxychloroquine. And we've obviously got Donald Trump there promoting it across the pond, and there was some interesting breaking news this evening about whether there might be invested interests in that promotion. But with regards to our patients in the UK, our understanding is, and what we're being told by our chief pharmacist, is that there is no problem with supply. My only slight concern, I have my own theories around this, is we might end up with a bit of a toilet roll situation, whereby if everybody keeps saying there's problems and the patients start getting concerned, they're going to put in more repeat requests earlier than maybe they need them and start a little bit of stockpiling. So I did an NRAS webinar last night and really highlighted to patients to be responsible at this time. Don't go panicking that we're going to run out of certain medications and starting to put in scripts earlier than, because obviously if everybody starts to do that, we are going to end up with a problem on our hands.
Absolutely. I mean, we've had that as well. We'll talk about two other things, if that's all right. There's one thing that we haven't actually mentioned, which is non-steroidal anti-inflammatories, which is mentioned in the NATO's guidelines. And I think that was a slight, again, a bit of over-egging of not very mature evidence. What do you think? What's your opinion on that?
No, and I think that's a very fair question. I think when all of this was breaking, there was some information came out, and concerns about prescribing and taking ibuprofen, and that was quickly, I think, if you like, put out as being not correct. And so the guidance, and especially for our patients, we've got lots of patients who will be taking anti-inflammatories, is that if you're on an anti-inflammatory, you don't need to stop. And we don't need to be worried about advising our patients to stop those medications. But you're right, it sort of suddenly took off on social media, didn't it? So
absolutely. Again, just one of these. Right. Let's talk about starting medications. And do you think people need to think differently about starting DMARDs and biologics at this time? I know that there's a bit of a difference in opinion across the rheumatology world about this. So if you talk to the Americans, they've got a very different opinion. And if you could go to Rheum Now and Jack Cush and all the rest of the people in the wider rheumatology sphere will have a different opinion. What do you think the pragmatic thing is? Because you're approaching this from a very practical point of view.
Well, I think the first thing to say is the importance of a shared decision-making process with the patient. I think, just at the best of times when there isn't the worries about a virus going round, like COVID-19, I think it's quite a daunting place to be discussing starting a drug that dampens down your immune system and increases your risk of infection. So I think explaining that in the normal day-to-day context is quite daunting for patients. And now we've got to try and, if you like, persuade them that the right thing to do is to start a medication at a time where there's these concerns about COVID-19. So I think having an informed discussion and just realizing the importance that the patient at the end of the day needs to be comfortable with that medication that they're starting. And it may be that some patients will defer and you feel, well, I'm not too sure that's the right thing. We're going to be in this for several months. But they might choose to defer starting these medications. And I think we need to, most importantly, be very respectful of those decisions at this time and just offer them the opportunity that if they change their mind, then to get in contact and we can take the necessary, make the necessary arrangements. But there's been a lot of talk about thinking about, we obviously methotrexate for patients with rheumatoid arthritis is always our preference, but maybe considering drugs such as sulfasalazine, hydroxychloroquine, which have more immunomodulatory effect. And offering those options to the patients, because those are drugs that we're not saying need to stop, and we're not saying that they put the patients at a higher risk of infection. So thinking about those combinations, if you're escalating patients onto a biologic, again, thinking about the half-life of drugs. So we've put some guidance out to suggest that maybe thinking about etanercept and JAK inhibitors, shorter half-lives, might not be a bad thing to be taken into consideration at this time. Yeah. The other thing to say is about steroids. So we produced some guidance. The BSR produced some guidance together with other organisations around the use of steroids at this time. And the worry is that steroids reduce the body's clearance of the virus, and therefore we need to be mindful about how we're using them. And certainly, our option within our department has been to give patients sort of reducing courses of steroids over a few weeks rather than going for IM injections at this time. And also it means that they don't have to come to the department to a hospital setting to get those injections.
Absolutely, these are lessons that we learned from MERS and SARS, which are the other types of the coronaviruses that have had epidemics in the past. So it does seem very pragmatic that oral steroids will be the way forward. You come to the thorny issue of bloods. I work in a hospital trust. We have a hybrid method of looking at them. So the first 3 months are in the hospital, next is in the community. Patients are forever phoning about blood investigations. Is there a way for a rheumatologist to navigate their way through which patient needs which bloods and what frequency?
Well, we have our BSR guidance, don't we, for monitoring of DMARDs and for biologics. And with my previous hat of chair of standard audit guidelines, I'm not going to say that we go against guidance, but I think these are pragmatic times and resources are stretched. And in patients who are quite stable, both the NICE guidance and the NHS England has given, if you like, pause for thought as to whether in very stable patients the frequency of blood tests can be reduced. But we have shied away from saying exactly which drugs at which basis. It depends again on an individual patient basis. It also depends who's doing the bloods. We're a community-based service and we've never been able to successfully push out shared care to the community. We were just in the process of starting the work when all of this hit. So we still monitor most of our patients in-house so we can keep track. But I know anecdotally from a neighbouring trust that they face the situation the GPs at the moment can't do the blood tests, and so the patients are phoning their rheumatology department to ask, can you organise my blood tests for me? So I think this is a very nuanced, it will depend on your department and such, and it may be that people need to sort of sit down and have a think about, what groups maybe can have their blood spaced out a little bit more. And it's particularly pertinent to the shielding group. We're asking these patients to stay indoors for 3 months and to self-isolate, and then we say, but by the way, can you come and have a blood test?
Yeah.
So what we've done with our shielding group is we've looked at when their blood tests are going to be due during this 3-month period, and if they're quite stable, we've talked to them about whether we just push it back a month. And the other thing we're very fortunate is that because I work as in a community based trust as part of a community trust who provides the phlebotomy service, we've managed to negotiate with our phlebotomists that they're going to go out to the homes of our shielded patients and do their bloods in their homes.
Yeah, well, we've had very similar from the hospital trust and the community trust as an accountable care group. We've actually had an agreement that we put some phlebotomy resource in primary care, and they've established clean and dirty phlebotomy areas out in the community that we're sending our patients to. But I suppose it depends where we're going to be working. Last but not least, how about prioritizing appointments? This is probably the most important question. The referrals aren't going to be stopping coming in. How should you prioritize it? How do you prioritize referrals? What do you think? Is there any advice for our colleagues?
Well, I think this is where the guidance from NHS England and the NICE rapid guidance really helps departments, because what that helps you to do is to give you permission as to what you need or what you need to keep running and what you can step back on. So both of those documents support that we should still be seeing our urgent news, our suspected GCA patients, vasculitis, patients with suspected EIA are also included in that. But it gives you permission to step down seeing routine referrals. What it does do is encourage departments to reach out or provide a mechanism by which referrers and primary care can contact for advice. So pushing things like advice and guidance is important at this time, and it might encourage us to think of different ways of working. So we're always seeing, well, what are we going to learn from this? But we've struggled to really get referrers to engage with using advice and guidance on our patch, and we think that this might be a good mechanism to say, actually, there's a way you can put those questions to us. So I think we all need to work together to support each other at this time.
So one of the things that we have done is that we've now got cyber referrals, and we're asking patients if they have an email address and the ability to use a mobile device that we actually then do it via video link and organize the tests remotely for them, and they can go to their GP practices for the blood tests. But that's something that we're sort of like doing, and had to go through quite a few data governance points before we could get there and use the right software to be able to contact the patient securely, to be able to have that sort of consultation. And there's something about getting the patients in a safe way so that they're not all waiting in a waiting room, making sure they're socially distant in waiting rooms, changing the geography of departments. Is everybody just taking a pragmatic view of that? Because I just went into the waiting room in my hospital and just made sure every single chair was 2 meters apart from the other.
Yeah, well, I think there's an option. I think most departments moved. I would hope, in the last couple of weeks, I would hope that most patients and most appointments have been moved to telephone appointments. So for follow-ups, certainly we moved very, very quickly to telephone appointments for all of our routine follow-ups. And for our new patient referrals, we are now looking at doing most of those by an initial telephone consultation. And because we're only seeing urgents now, it's actually small numbers. So we spread them out during the week. Each consultant has a new urgent list, and we bring up 4 patients each time, and we give them 45-minute slots so that we can hopefully, we don't have too many people congregating in the waiting area. And for our blood monitoring clinics, we're doing the same. We're policing it. We're only allowing 3 people in at a time. So I think we all have a responsibility to sort of make sure, and sometimes that is a logistics, and you need a few extra pairs of hands of staff just to make sure you've not got too many people. Again, that comes down to the nuances of your individual services. We're moving to video consultations, or having the option to do video consultations from next week. We've just been using telephone otherwise. So
that's going to be an interesting one from there. Well, I think that, that's basically quite a good flavor, and thank you very much. We sort of like managed to cover most of the things. What we'll do is that we'll stop here and take some questions from the audience, and hopefully we'll be able to answer them as we're going along. Thank you very much, Lizzy.
Thank you.
Brown cover there, and Marwan, pop your cams and microphones back on. Thank you very much. I'll defer to Marwan very shortly. Just say we've had quite a lot of questions asked during that period, so we will try to get to as many of them as possible, and our moderator Jack is going to load the questions up onto the screen so we can all see what is being asked and what's being answered. Okay, I'll hand over to you now, Marwan. Thank you.
Okay, thank you very much. And thank you all for being really lively on the side. I've tried my hardest not to answer too many of the questions as we're going along, because I think that we should put Lizzy on the spot a bit more and see what has been happening. But there's quite a few political ones that have gone through. Let's start off with our first question. It should be popping up any second now. So it's great works for adults, nice and clear. But what about peds? The pediatric population has very different needs. What's happening there?
So the stratification guidance for the shielding applies to adults and children. So that's the first thing to say. And our colleagues from BSPA were involved in contributing to that process. So the stratification guide is for both. And also the NHS England guidance and the Rapid NICE guidance again applies to adults and peds. And we have ensured that our colleagues from pediatrics have been involved in the group that have reviewed those documents and commented. I know the next round, or the updated version of the NHS England guidance for our specialty, we've made sure that peds are specifically mentioned in that, because I can't, but the colleagues have been involved from pediatrics as well.
Okay, right, next question. One of the challenges we all face after COVID is how to manage the backlog of work, and how do you triage those in need and restructure the services? And do you think that the BSR could be involved? Because they might just say, listen, why do you need so many rheumatologists? Why not just do it all by phone, triage everybody, not see that many, and we don't need one rheumatologist for every 83,000 population.
Tomorrow's giving us our answer. We're all going to be out of a job. So, no, joking aside, I think we're all trying to deal responsibly. I think I'm always a great believer. The glass is half full with me. I'm always looking for the silver lining, and I think out of this we will have explored very, very different ways of working. If someone had said to me 6 months ago, you'll be doing all your appointments by telephone and feeling quite happy with it and typing your letters live, I'd have said, no, you must be joking. But yeah, I've been amazed how good a job you can do on a telephone. Our physios have really engaged with our axial SPA patients, and finding that they're getting a much better discussion about what they're doing for themselves. They're particularly been able to focus on self-management techniques with them and such. Certainly I work within an MSK, an integrated MSK service, and our physios are absolutely thriving off doing patient assessments remotely. And it gives me an opportunity just to highlight there's been some fantastic information produced by the CSP to support patients with exercises at home and remote consultations, which is definitely worth a look at. The links on the BSR COVID-19 FAQ sheets. If you go onto that, there's a link to the CSP site.
Okay.
So,
I mean, just a supplementary question to that, though. I mean, is the BSR going to be providing a guide or a template for how a telephone consultation will go, and what the minimum clinical important things that you should be asking in an inflammatory arthritis or connective tissue disease consultation will be, or is that something that you haven't looked at doing?
I mean, I don't think you're doing anything different by telephone that you are to do on you know, on a face-to-face. Obviously you don't get to examine the patient and such, and you don't get to take their urine, check the blood pressure and such, but I think as far as how we deal with this and the fallout, the guidance that's been produced by NHS England is there to support us as teams. You're completely right in that it doesn't as yet give us the answers exactly as to how we then recover the workload that's been put on hold. And you know, I hope that it will see us working more efficiently and better. But I would hope that we will still have you know, have the work there to do, and we can look at from the BSR perspective how we support people through that process. But at the moment, it's a bit difficult to think that far ahead at this time. But certainly we can start to think about that in due course.
That's a good idea. All right, next question, please. We've had loads of questions. I'm not sure we'll have enough time, but we'll carry on. Are there guidelines to advise how long patients should wait post-COVID before it's safe to restart the DMARDs? Fantastic question, because there's probably not an answer to that. It depends on the half-life, if you were going to ask me. But what do you think your official line would have been?
I think, well, what we've put on the website at the moment is obviously if patients develop symptoms of COVID-19, then they should stop their medication for the time that they are symptomatic. We haven't given any specifics about when to restart, but certainly from an anecdotal, what we've been advising is once their symptoms have subsided. So I think once they are completely symptom free, and we know that in some patients symptoms can drag on for some time.
Yeah, how about post-viral cough? Because post-viral cough we've seen in our colleagues just lasts for more than 6 weeks afterwards. I mean, as you know, we've got certain members of the rheumatology community with COVID, and they're still coughing 2 weeks later.
And I think we don't know the answer, and I think sometimes it's very difficult to say that as a clinician. We want to know the answer. We want evidence on which to base our decisions, but I think at the moment we are in difficult times, and we all feel a bit uncertain. But I think with those patients, it's assessing their symptoms, and again, you know, taking each patient as an individual. The worry obviously is if their condition then flares as a consequence of them being off treatment, then it's what drugs you use. And at the moment, we've not everyone being able to be tested to confirm it definitely is COVID-19. So that's the other frustration, isn't it?
I'm sort of bypassing it. There was a question from my colleague, Dr. Bilgrami, online that says, well, how do you treat a flare? Is there any guidance on that?
Well, that comes down to the steroids, doesn't it? We've got our guidance on steroids. And yeah, I think it's fair to say a lot of us are opting for reducing courses of oral steroids. Again, that shared decision-making process with the patient as to what it means to give steroids at this time, and trying to avoid bringing patients unnecessarily to a hospital setting, you know, to have an injection if it can be avoided. And again, if patients understand that there might be a risk, I've had a lot of patients, well, we've had quite a number of patients ring up who are flaring, and when we explain that there's concern about using steroids, they've actually said, oh, you know what, I know it'll settle in time, I'll give it another week or so.
Okay, fair dues. Next question, please, from the audience. Who has or should have responsibility for informing patients regarding risk and how that can best be done? It's been clear as mud to patients, causing fear and misunderstanding. Have you had any patient input in any of this?
So we talked on the video, so I won't go over. I mean, I think it's been quite clear in the message to BSR members that the responsibility lies with their teams or their rheumatology service to identify those patients for shielding. And it depends on the team then as to how you do that. As I said, we have been very fortunate that we've had the resources to be able to phone every patient and explain what this means and just explain what will happen about their appointments, bloods, etc. But we haven't been deployed to the front line, and I'm aware that colleagues down in London have not had the opportunity to go through stratify and send out the letters and have such a personal sort of message to patients. With regards to patient-facing guidance, it has been really challenging for us because we have produced guidance for our members, and we are a society for the rheumatology community and the clinicians that work in that community, and we've had to shy away from producing actual patient-facing information just because there has been so much asked of us. But what we are very fortunate is that Versus Arthritis has produced a patient-friendly version of our stratification guide and the scoring system so that patients can understand the process and what puts them into the shielding category. And we've also been working closely with NRAS. I've done 2 webinars over the last couple of weeks just to help them answer questions, and they've been sending me through queries with individual patient queries. So we are trying to get to work with our patient societies to develop those patient-facing materials.
Okay, there was a supplementary question to a question you answered earlier, and what oral dose of steroid are you using? That's just come through on the right-hand side. There's been quite a lot of scrolling.
Yeah, so I mean, again, it depends on the individual patient, but if they've had a flare that's bad enough and that they are going to need some steroids, I've been giving patients 20 milligrams for a week and then reducing down by 5 milligrams every 5 to 7 days, depending. And obviously, if they're depending on their weight as well, so lower doses if they're a little bit lighter.
That's about commensurate with what most people will do. Next question. Although you say there's agreement between specialties, from the guidance that somebody has seen, there's a difference in the stratification between specialties for dermatology and rheumatology. The Derm Society seems to recommend shielding if patient is on a biologics and an oral agent like methotrexate, where BSR doesn't assume it doesn't, assuming there are no differences in the comorbidity.
I saw that question pop up and was hoping. So this is frustrating because there was an enormous amount of work went into the teleconferences and the discussions to make sure that we aligned, and it hasn't absolutely been followed to, but there were significant discussions had. I use the phrase that my family always pull me up for, which is we are where we are. Our guidance is published and we are following it and such, and we did that in the good faith that we were going to be followed suit by other specialties. So I don't have an answer, except that at the time that we were having those discussions, there was an agreement as to where patients on 2 immunosuppressive drugs sat.
Okay, well that's fine. So let's go to the next question. There's a really good humbling here that just came in saying, if a patient being put on steroids goes into shielding, yes. How long does it take before you put them, when you stop the steroids, you put them back into the category?
Yeah, so the bit to work out with that is how long they've been on steroids. So the guidance does say we're talking about people who've been on continuous steroids. So it's, and we talk about a dose of 20 milligrams or more for 4 weeks continuously, or if you're looking at lower doses in combination with other drugs, then 5 milligrams for more than 4 weeks. So hopefully that gets me out of that one.
Okay, that's that question answered. Thank you. Okay, next question, please. From we answered the last one. So, what are your views on immunogenicity to vaccinations from our patients on biologics? Can we extrapolate data from influenza vaccines? Is it likely to differ with the coronavirus vaccine? So, if it does come around, what are we going to do?
Well, I suppose I might defer to your knowledge here, Marwan, but I suppose it's going to depend on the type of vaccination, because obviously if it's a live vaccine, then we're going to have some issues.
Yep. Well, it won't be a live vaccine. So what we're probably going to have is polysaccharide vaccine. And I suppose aside from patients on rituximab, you could probably, as long as the patients have taken 2 half-lives of their biologic, they could probably get vaccinated. But the risk that you're going to have to explain that the risk of them stopping their drug for 2 half-lives will be about a flare of their drug before that happens. But let's cross that bridge when we get to it, and we can do a full webinar about vaccinations. And I would love to engage our colleagues across the Atlantic in this. So if we manage to get Jack Cush on the line, he'll give you a different answer from that point of view. So next question, please. Could the BSR, this is a political one, you can answer this one. Could the BSR support a national pathway supporting treatment of COVID hyperinflammation if they're not in a trial? So for example, I can give remdesivir, I'm part of the other trials, I'm randomizing patients on my COVID ward, and I'm randomizing them to different trials depending on things. But if somebody is in intensive care and has got that cytokine storm, could the BSR support saying, could we give them, let's say, experimental tocilizumab if all the chips are down?
So I suppose the big part of that question is if they're not in a trial centre. So the first thing for me to say would be to go and approach your research units and try and encourage them to get involved. I know that these trials have been set up extremely quickly. I think they've broken all records. And I know if there are other centres, they're still looking for sites to recruit. I'm not 100% sure, I have to be honest. And that's partly because I don't work in acute trust. So that would be my first part to my response. And then the second thing is to have a discussion with your medical teams as to whether you can get use on compassionate grounds. And by all means, what I would say is drop us an email and we can have a think about whether we can support. I think the problem at the moment is there the evidence to definitely support the use of these drugs? And we know that there is some stuff coming out, and there's stuff around the use of tocilizumab, as well as the trials that have been going on as well. There was a couple of, there's been a few tocilizumab trials, hasn't there, Marwan? So,
So we're probably going to know a bit more about the preliminary results of data. Well, it should have been Friday this week, is the preliminary results of some of the early ones. Unfortunately, some of the investigators have gone down with COVID themselves. So we will just see what happens there. Can we have the next question? We're running slightly over time, but I think we'll just answer as many as we can. Does the NHS England shield identification then trump the BSR guidance? Well, somebody used a dirty word there. Even though we would not identify them as needing shielding?
No is the answer. The BSR guidance is what we should be using to identify patients for shielding. A part of the difficulty, as I alluded to before, is that the NHS England guidance came out before the BSR stratification process was done, before we were approached to identify that cohort of patients. And there is going to be some slight adjustment to wording coming out with the NHS England guidance, we think, from the comments that we've put into it around single biologic usage and how they're classified. Just the other thing to just pick up on, I know it's been quite a big thing on the comments, is how patients are notified. So we have asked members to identify their cohort, send patients out letters, and then alert their GPs, and that the GPs will code them on their system as COVID-19 high risk. We have now learnt that the process is actually slightly different, and the GPs haven't yet been given access to code to be able to code these high-risk patients on their systems. So they may well be able to put alerts on for their individual practice, but it doesn't go any further than that. So what we have learned over the last 48 hours is that each trust has a COVID-19 link. I think Alice put a link on the chat to, if you don't know who it is for your trust, someone to email about that. And what you then do is you get in contact with that person to send them your list of patients, and they will then upload that to the national system. They'll send it through to Public Health England.
Okay, there's several other questions coming through. There's a few that I can probably answer on everybody's behalf. The number of patients with rheumatological complaints who've had COVID, just looking at the case reports and from the articles that have been submitted, and from the 66,000, I think, that have come from Wuhan, there was a significantly small amount of patients on rheumatic drugs, and there didn't seem to be any signal that came through. And all that we're seeing so so far is that they behave the same as everybody else, but there's nothing that indicates that our patients are at any higher risk from what's been published to date. Now, the Wuhan data is probably not the best of clean data from our point of view. So the Italian data hasn't really arrived yet. It's probably going through the processes in a different journal, probably in the Annals. So watch out for that. We haven't had it, but our case reports so far that have come to my journal haven't shown anything. The question is, we'll answer the next question, and then you'll talk to us about hydroxychloroquine, I hope, because that's been a question there. Next question. Oh, pending that popping up on the scene. Oh, nice. Recent guidelines mention changing patients from IV to subcut. Is this happening, and how practical is it?
So there's obviously we've got tocilizumab and Bataset, which have been available as subcut preparations for some time. So if units have patients on those IV preparations, then certainly it's worth considering getting those switched over. Infliximab is available now as a subcut as well, so that's another one. But I think at the moment, a lot of it depends on the resources available to your team for doing this. A lot of departments are having a look at patients coming up from fusions because they're coming to units and the staff are being pulled to elsewhere. So it's how patients can get their treatments. But the other issue with some of the delivery of some of the home care providers. I know we've had one home care provider we use which has stopped taking new registrations, and a couple of them are no longer sending the nurses out to do the visits to show patients how to give their own injections. So I think it's fair to say, and I think Lynn is one of our patients who's joined in tonight, if I remember rightly. But I think what is happening is units will be looking at their cohort of patients, and where it's appropriate, be thinking about switching them to subcut.
Okay, right, next question, please. I see a very, very intriguing comment from Murthy talking about post-COVID fibromyalgia. I hope we don't get to that question. How does interferon fit in the BSR scoring system? I've just only a few, but there are patients on this for Behçet's.
So a very good point. And I'll be honest, I fear that that's probably been an omission on our part because we have not included that in the biologics list, but and I suspect we should have done. I suppose the other question is whether it's included in any other specialties guidance, but I'll take that away and we'll look into that.
Yeah, that's not on my radar at all. Right, next question, please. The BSR recommendation is not to stop denosumab, but elderly patients largely fall into the most vulnerable category. A risk of rebound fractures highest at 9 to 12 months following stop last denosumab. There's some scope for risk assessment and slight deferment. Many patients don't want to leave their house for it when offered. And the advice, please. And I think this is a really important one. I mean, in my locality, denosumab is amber, so if you're already on it, the GPs can continue to prescribe it at home, but it depends on your location, I suppose. Lizzy, over to you.
I think this is again a similar situation to the newly diagnosed patient who's apprehensive about starting treatment. I think what we've said within our the guidance is that ideally we shouldn't be postponing treatment of denosumab, especially knowing that this is going to go on for several months. But that being said, you've got to take each individual patient and have a discussion with them, because like Nora's highlighted, a lot of these patients are elderly, frail. They may well be in the shielding, the high risk group. So is there another way we could get their injection to them? Could someone go out, from the district nurses, who I know are being seconded to do a lot more work that patients would normally go to their practice nurses to have done. So thinking outside the box a bit and having that shared decision making process with the patient, because they may well say, well, actually, you know what, the only thing I can do to get it is come into the department and have the injection, then I'd prefer not to at this time. So that's fine, we involve the patients in the discussion as well.
Okay, that's great. I mean, there's quite a lot of chat on Twitter and everything else, but I think we're running out of time. It's been quite interesting just having this chat with you, Lizzy, and there's going to be lots and lots of questions, and maybe we could field some of them at some later date. So we'll just look to our colleagues at the BSR to maybe for us to have an update from clinical affairs at some point.
Yep, thank you both for joining us tonight. That's been has been incredible. We've had so many questions in. We will try to work through them. We'll try to feed them into consideration for any future guidance. So just before we end the session, I'll just share one further resource. So if you're not currently a BSR member, you can sign up to a newsletter so that you can be informed about any future information and webinars and so on from the Society. So I've just popped that up on screen for you now. In addition, I'll just load up the last slide to say thank you very much for joining us. We would like to bring more COVID webinars in the coming weeks if we can. And as I say, if your question wasn't answered, then please do let us know on social media, or you can email our policy team, who are collating lots and lots of inquiries all the time. We will make this webinar available to everybody as soon as we can, and we'll share information with you. So thank you very, very much for joining us. Thank you so much, Lizzy, for doing that, and thank you so much, Marwan, for hosting. That was fantastic.
Well, thank you all very much, and thank you for all the very interested questions. And hopefully, you'll all follow us on Twitter and look up the journal and keep reading. You'll be hearing quite a lot about COVID in the next few weeks.
Can I just completely forgot to plug? We've got our members forum. So the members forum, you have to be a BSR member, but if you go to the members forum, we've got a COVID-19 theme. Anybody can access it. There's no permissions to get whatever you post checked. But if you've got resources you want to share, links, information, questions, please use it as a resource, because we are probably the most valuable people to each other at this time, is discussing things like we have done tonight. Thank you for listening.
Yep, and thank you all for all of your support for each other. Thank you.
Thank you very much, everyone. See you later.
Bye.
Goodbye.